talk. What are we going to talk about? Damn, what are we going to talk about?
Bony
Rib
Thorax.
x-rays. Ribs, sternum, and SC joints are in this chapter. So, we'll do some ribs here. Ribs, there's a couple ways you can do ribs. You can do them with an AP projection, or you can do them with a PA projection. So either AP or PA. Depends on the history of the patient. Okay? The history of the patient dictates our projection.
Is there a probably
It dictates
Oh.
what the history of the patient
Have like a
is.
posterior rib.
Okay? So if a patient comes in, remember we always want to get the area of interest as close to the IR as possible to get the best recorded detail. So if the patient comes in with posterior rib fractures, what would be the projection?
AP.
The AP, exactly. Patient comes in with a history of anterior rib fractures, then you do on PA. Make sense? Easy as that. Easy as that. So I'll show you guys both ways of doing this, and it just depends on, again, the history of the patient. I need a patience. Advanced, come here, girl.
You can't be volunteering your way back there.
What are you looking up there?
She's all jacked.
We're gonna use her next. She's next.
Janice.
Janice is next, man.
She volunteered herself.
She opened her mouth, she just volunteered herself. That's how that works right there. Alright, girl. Okay, do me a favor, take that off for me. That clip. Do you have markers I could use?
Yeah.
Cool. Stick those in the bucket for me. Okay, so rib x-rays are like chest x-rays. They're very close to each other. We still want to center at T7, which is the center of the thoracic vertebrae and the ribs. So we center very similar to how we would for like an AP chest. You go 3 to 4 inches below the jugular notch. Or if you have like a thinner patient, put a little bit of light above the patient's shoulder. Just like a chest x-ray, right? We're going to put a little bit of light above her shoulder. It's going to come out absolutely amazing. And then we're going to cheat a little bit to the affected side. We're going to do unilateral ribs. So we're going to cheat a little bit to that left side or right side, whichever the affected side is. Okay? So let's say that Adriana here was, she's got, we interviewed her, got her history. She's got left posterior rib fractures. Maybe she was out in that club one night getting her groove on, and she was hitting it hard, doing this shit, right? With some dude, some John out there, man. All of a sudden, a girlfriend came out of the bathroom and said, "What the hell?" Now you know how women carry bats, right? And she hit Adrian in the back. Girl, boom. She said, "Oh." So she would say, "Yeah, brother, I was at club one night. I got hit in the back."
True story.
True story, huh? You know this is true, girl. So she's got posterior rib fractures on the left-hand side. So we're going to do them AP, right? So how ribs work is we do this 5 views for ribs. We always start with the PA chest x-ray. This is a regular chest x-ray. I'm not going to cover it because you guys know how to do chest x-rays.
So for the exam, are you gonna give us like, okay, what view you want us to do?
I will give you a scenario. She comes in with anterior rib fractures and posterior rib fractures.
Okay.
Yeah, so you know I never make things easy for you. So
just to double check. Anterior is the PA, and posterior is AP.
correct. Correct.
And then you just do a chest for either or.
So you do a chest. You always do one chest x-ray. Okay, regardless of where the area of interest is. We're looking for, like, you gotta remember those ribs that each rib has an artery, has a vein, and it has a nerve, right? And when you break those ribs, usually they puncture something, and the blood leaks into the pleural space, so you get a pneumothorax. Sometimes it introduces air and gives the patient a pneumothorax. So chest x-rays will always rule out hemo or pneumothoraxes. So we always do a chest x-ray. Also, it determines if we do an AP chest or a PA chest, whether or not the patient is ambulatory, just like a regular chest x-rays. So if they come in, they're non-ambulatory, we shoot them AP. And then we would do the ribs on the table for non-ambulatory patients. If a patient come walking in though, we're gonna do a PHS, and we're just gonna do all the ribs standing. I wouldn't ask my girl over here to lay down on her broken ribs, because that would hurt, right? So we might as well just do them while standing. Okay, so ambulatory versus non-ambulatory too. Okay, back up a little bit for me, girl. If she's a smart patient. She goes, you need to call and make your field size first. Look at that, girl. You knew what you were doing. Put your back up against this one.
14 by 17?
14 by 17. And it's already actually positioned perfectly. I got a little bit of light above her shoulder. I would lead it. I knew I was going to use her. I was like, how tall is Adrian? Girl's about this high. This is what I'm going to need right here. See how well I planned that? That was such perfect planning right there. Okay, so we got the height of it. I'm going to cheat a little bit towards the left side. I'm going to do unilateral ribs. So I'm going to center halfway between the sternum and the lateral rib margin. Here's your lateral rib margin. Here's the sternum. Take a small step to your right. Maybe like itty bitty step. Okay, a little bit too far, but now you're getting crazy on me. Alright, so what I'm going to do is I'm going to collimate. I'm halfway between her sternum and her ribs now. And if I palpate her jugular notch right here, sorry, I'm probably cold. I can feel you feel warm, so that tells me my hands are cold. But if I palpate her jugular notch, I have a whole bunch of light on the right side of her spine, right? I just want to collimate in to where I have a little bit of light on the other side of her jugular notch. We always have to include the spine in these views. Okay, you cut the spine off, you redo it. We got to make sure we get the rib articulations with the spine. So you at least have to get half of the spine on your view. And you do that by just collimating this way just a little bit. So we have a little bit of light right there. That looks pretty good. I'm going to use marker all dirty. Oh, your sticky things is not very sticky anymore. Okay. Put that down a little further. Upper ribs on full inspiration. We want the diaphragm to drop, and we want to see as many upper ribs as possible above the diaphragm. All right, Adrienne, take a big breath in. Hold it. Don't breathe. Don't move. Beep. You can breathe. Okay. So there's two. We already did the chest x-ray. We did this one. So we have to do 2 uppers and 2 lowers. All right, so we got 1 upper out of the way. Now we're going to oblique her. We're going to put her in an LPO. Your book says about 45 degrees. Sometimes 45 is a little bit too much. But that's pretty good right there. And what you want to do is you want to center the crosshair on the sternum. So her sternum is like right here, so I'm going to take her and just do this. About right there. Okay? And you guys see this light on her neck? I want light on the side of her neck. So I'm going to open up this collimation like so, to where it's on the side of her neck, just like that. And if their arm is close to the ribs, you can slightly abduct their arm a little bit, just to get that out of the way. I don't want to have to pay extra for that. Charge extra for that humorous x-ray that we get there. Okay, big breath in and hold it. And then beep, you can breathe. You don't actually have to breathe at least. You're okay.
Okay.
So it's still 3 to 4 inches below, right? You just
Same thing.
And centered it on the sternum.
Center on the sternum. Because when we do this,
No, he didn't touch the light at all.
He just opened up the collimator back to like.
when we do this right here, if I'm the Bucky and I oblique the patient, here's the spine, here's the lateral rib margin. Look where the sternum is. It's right between my hands, right? That's why I say center on the sternum for the obliques. Cool?
Yeah.
So there's 2 uppers out of the way. 1 straight on, 1 oblique. Now we're going to go down the lowers. Take a big step to your right for me. I'm going to collimate to like a 10 by 12. Okay, come on back. Before she comes back though, I'm going to put my marker to pre-mark it in the lower left-hand corner.
Which one's this one?
The lower ribs. And the book says midway between the xiphoid tip and the lower costal margin, which is good, it's fine for a written test. But probably the best way to do this is put the bottom of the lights at the top of her crest. So the top of her crest is right here, I can feel it, right? Just above her pockets. So we're gonna drop it down, so it's just above her pockets. And I'm gonna open this up. Just like so. And we're going to center midway between the sternum and the lateral rib margin. So take a small step to your right. Perfect. Good. Perfect. Just like that. Take a big breath in. You don't have to breathe. And we're doing a full expiration. Big breath in. Blow it all out and hold it. Diaphragm goes up so we can see more lower ribs. Usually the KVP range for upper ribs is about 66 to 70, 75 in that area. We want a more of a high subject contrast image. When we go to lower ribs, patients are normally a little thicker in the bottom part. So we need to bump up the KVP by like 5 to 7 KVP in that area. Just to get more penetration. You have a question?
Shoot. So the center of the CR we don't care about because as long as we're putting the bottom of the light on a 10 by 12 above the pocket.
Correct.
Right?
Correct.
And then it's on expiration?
You want to center it halfway between the sternum and the,
Right, but like
yeah.
the dead center part.
Nowhere to center for your written test though.
That's
Okay.
what, between the costal margin and
Lower
what?
costal rib margin is xiphoid tip.
Like
What was your other question?
process and lower
Oh,
rib margin.
expiration or inhalation?
Full expiration.
Expiration.
Thank you.
And
But the
you say,
diaphragm
10
will
by
go up.
10 by 12.
10 by 12. Diaphragm to go up so we can see more of the lower ribs.
Okay, let's say 14 by 17.
Nah, I don't need a 14 to 17. Maybe we're on the upper still.
No, it says lower.
Shame on that damn book.
So the center is
That's why I
xiphoid tip
don't
and
open
what?
It says midway for a xiphoid.
Lower is
process
10 by
and
12.
Lower rib margin.
You don't open that one?
Okay, and then we're going to oblique her.
Tip and body left it?
And we're going to center.
Between xiphoid,
They're not even listening.
midway between
They're
xiphoid.
not even
process.
listening. Not even listening.
Okay, thank you.
Got their own thing going on back here.
Alright.
Okay, come on, who? So now we're gonna oblique the patients, and we're gonna do the lower ribs, and then we're gonna center this right here, that little vertical line again on the sternum, and abduct that arm for me just a little bit. Boom, full expiration.
On the sternum? So you didn't change your mic?
I didn't change the lights. I'm gonna go over this way a little bit more. I didn't change the light though. So full expiration. Take a big breath in, blow it all out, and hold it.
So it's like the same.
It is. You're
Just
just
oblique.
obliquing the patient.
Okay, I'm not gonna rewrite everything.
And center at the sternum, just like they for the uppers.
Okay.
Okay? So that's the lowers. I mean, that's the posterior ribs right there. Posterior rib fractures. We got 5 views. Chest x-ray. We got 2 uppers, 2 lowers. Okay? So let's say that she's got anterior rib fractures. She's still clubbing. But girlfriend got hit in the back because she was running from that crazy woman coming out of the bathroom, right? She was a smart girl. But instead of running, she was like, okay, I think I can take this little chick right here. So she like held her ground and she smack. Oh, hell no. She got hit in the anterior part. Now her ribs hurt on this right side over here. We'll do the right side because it's closer to me. Okay? So we're going to do these with the PA projection. So take a big step that way. We're just going to open this back up again where it was. Put your chest up against there. Just like a chest x-ray. I'll do that. I'll do that. Mark it. And take a small step to your left. I want to go halfway between her spine and her lateral rib margin. Because again, we're doing unilateral. So get nice and close. There you go. And about right there. I'm going to collimate just a touch. You know what? I'd probably even go down a little bit more, just a touch. Okay? Big breath in and hold it. And you shoot it. Okay. Now we're going to do the oblique. How I want you to remember these obliques is think of, you can relax, Adrian. You know that dorsal fin in a shark?
Yep.
You know how they're swimming through the water and it's kind of like this, right? Imagine a dorsal fin on their back, or even the spinous processes are kind of sticking out like this, right? Whenever you do these obliques, you always want to oblique the patient to where these spinous processes or this imaginary dorsal fin is pointing away from the area of interest. So she's got right anterior rib fractures. Which oblique are we going to do?
LEO?
LAO, because they're pointing away from the area of interest. Make sense?
So if we want here, we want them here like that.
I'm not quite sure what that meant, but.
I'm sorry. If I'm the
Yeah,
IR,
that confused
What's
me.
that?
if I'm the IR,
Uh-huh.
and here's the patient, and the right side is the area of interest, so I'm gonna put like an LAO,
Yes.
then the spinous processes would be LPO.
Huh?
Holy moly. Don't think it's
Whatever.
Just
I know your
dorsal
brain
fin.
works a little bit different, man. than
Wait.
mine.
Dorsal fin.
Could you animate it on the Bucky? Yeah, just like that.
Yeah.
So
Yeah,
do
so
it again.
on the Bucky.
Yeah.
Right? On the Bucky.
So we want, what's the, okay,
The
so,
right side.
So the right,
This is
the right
an LAO.
anterior.
This is an LAO. We're looking at the right side.
right, okay, that's exactly what I was saying. Just with
Was it
the
really?
words.
What-
Alright.
Can we
Wouldn't it-
just think of it side furthest from the IR?
Yeah, I
Yeah.
was gonna say, wouldn't
Yeah.
it put it away from the IR? Don't you want it closer to it, or no?
No,
Not in
because
this instance.
if we were to put it closer and do this,
It's blocking.
the spine is literally right over the
superimposed.
whole right side, right in the
Yeah,
middle of the spine.
Okay,
Yeah, so we would always do,
I see.
yeah. And you can think of it, away, like the upside. You know, you can look at this too, and we're doing the upside for a PA projection and the downside for an AP projection. And you can look at it that way too. Because we're all about upside and downside, right? So if you think about the AP projection, here's your dorsal fin, right? So if we're looking at this side, you want to do an LPO, and the dorsal fin still pointing away from the area of interest.
I wrote down dorsal fin.
But now it's the downside, right?
Yeah.
But remember, radiology is always the opposite when you flip the patient around. Now we're looking at the upside. So there's all kinds of different ways you can think about this. I'm not about your way. You just hit my
However way
head
you
there for a
understand it,
second.
Nick.
I
You just,
know.
so the spinous
You
process.
just sent my brain into a shockwave just now.
So the spinous process is something we're going to be familiar with when we're identifying radiographs on the written part.
Not necessarily. It's just a way for me to tell you how to
Line up.
know which oblique to do for certain body parts, right? It's just kind of a way where you could, the spinous process stay like this, right? So if you can remember, I'm going to oblique this patient to where the spinous processes are pointing away from the area of interest. It's as easy as that. And just remember, if they're anterior fractures, do them PA obliques. If they're posterior fractures, do AP obliques. But these still have to be pointing away from the area of interest when you oblique them. Make sense? Nick scares me. Every time he opens his mouth, he scares me, man.
Like that.
Because his way of thinking, he's got some tricky stuff there, man. He's even told me, he said, my way of thinking, this is how I remember. Like, oh, man, I don't know.
I'm gonna give him this.
cover my ears.
That confused me too, I ain't gonna lie.
So,
It's all good, but you know what?
It works.
Nothing really matters as long as it makes sense to you. You are what matters, my man. Alright. So, what were we doing with this?
We did the.
Oh, yeah, sorry, she was running.
right side.
No, she was
It was
she
an
had anterior fracture.
Yeah, anterior
That's
fracture.
what she got. So we're gonna oblique her, we're gonna put her in an LAO for the right side, just like so. I want to center halfway between the spine and the lateral rib margin, so about right there. And I'm gonna open it up just a little bit more this way so I don't cut that spine off. So I'd like to see some light on the other side of her neck again. Okay, and if you wanted to, I see light on her arm, I'm gonna do that. Okay? Maybe move her over this way just a touch more, about like so. Those actually aren't bad, they stick pretty good. He's got a push, initial push. Okay, full inspiration. You can relax. You can sit down if you want.
Is it 14 by 17?
I'm gonna do it again.
You wanna do these here? 14 by
You
17?
can take them. I'll use somebody else's. I'm gonna do them all over for you, so you can see it.
14 by 17,
Yeah.
except for the lower 10 by 12.
So big on top, little on bottom, inspiration up top, expiration on bottom.
Yes, that's it.
That made sense.
That makes total sense right there, right?
That sounds better right
That makes total sense. So just remember though, anterior fractures, you're dealing with PA. Posterior fractures, you're dealing with AP. And think about, I want you to think about the lower ribs. They're like this, right? The upper ribs wrap around the body like this. So this is why we do anterior ribs. But the lower ribs are like this. Especially 11 and 12, even like 10 and 9, they're still kind of going like this. So they're not anterior, right? So we don't have anterior lower ribs. So we don't do PA projections for lower ribs. We always shoot our lower ribs with an AP projection. So if the patient comes in and they have like Adriana, right anterior rib fractures, you're gonna do chest x-ray, you're gonna do your PA, you're gonna do your LAO, and then you're gonna flip the patient around for the lower ribs. AP lower, oblique lower, for the right side. Okay? So we want to do the entire ribs on one side. Does that make sense? So we don't do, again, we don't do PA lower ribs. They're always AP. That's why I didn't show you the AP ribs, the lower ribs on the, with the PA projections, because we already done them. Okay, make sense? Don't get that confused. Janice, come here, girl. Finish up right. Come here.
Dang, that was a high. I got all the eyeballs.
You got markers? Oh yeah, let me use the markers, girl.
Oh, damn you.
She got all kinds of markers on there. How many sets you got, man?
You got the 2 red ones?
All kinds of markers. All right. And this is done at 40 inches. Okay? 40 inches. I had it here because my cord wouldn't reach. My phone's probably going to die here in a little bit, so I'll try to plug it back in. But that's the only reason why I had it pushed back a little bit further. Okay, but this is done at 40 inches. 40 inches. The only one that's done at 72 inches in this chapter is the lateral sternum. Okay? All right, Adriana, you ready for this, girl? This is only for you. Nobody else can listen. All right, girl, you in club? What were you doing? You out clubbing too? It was like a tag team. You both got hit. Everybody get ribs. I'm gonna be like Oprah Winfrey. You get ribs. You get ribs. Everybody got ribs.
Janice was trying to come in,
Right?
and she got punched.
Not my girl, I gotta protect her.
I know.
All right. Take a small step to your right. Damn, girl, I said a small step. Get back over here. Where are you going? Small step. Right, there you go. That's perfect right there. Good, right there. Okay, so you notice I put a little bit of light above her shoulder like I was taking a chest x-ray, right? I'm halfway between her sternum and her lateral rib margin. And make sure you take off all the jewelry, necklaces, bras, all that good stuff too, obviously.
And which view?
This is an AP for posterior rib fractures. So about right there. And I'm going to put her marker right there. And we're going to do, you don't have to breathe, but take a big breath in and hold it. Okay? And then we're going to take her, and we're going to oblique her. We're going to center on her sternum, which is about right there. Just like that. I'm going to open this up to where, see the light now is on the side of her neck? Right here on the side of her neck, right here?
Yeah.
Okay? So we're going to take that. I would probably abduct that arm a little bit so I can see her arm in the light. I don't want to catch that elbow in there. and then you take it on full inspiration again.
How come, the SDR, SID here says 72?
I don't know.
Yeah, it's a 7 kilo rack, 40 we're coming up. Just
So
40.
are you teaching us?
Always 40?
40.
Always 40? Okay,
40
I'm gonna
inches.
change it.
40 inches.
Yeah, still black.
Okay, and then lower ribs. Take a fix. Now you can take a fix up that way. Okay, come on back. Actually, wait. Pre-mark it. There we go. Okay. Alright. So what we're gonna do now is we're gonna take this and we're gonna drop the bottom of the light to where it's at the top of the crest. So the top of our crest is like right there, right? So that's right there. Just gonna line this up. There we go. Take a small step to your right. There we go. So you're about ready to make this big old huge step again, huh? Okay, so we're now halfway between the sternum and the lateral rib margin. Full expiration. Take a breath in, blow it all out and hold it. Okay, and then we're gonna oblique her. We're gonna center on her sternum, which is about right there. Duck that arm just a little bit. Take a big breath in, blow it all out and hold it. Okay? The most common error I see with these rib x-rays is you guys cut the spine off. So make sure you don't cut the spine off. Okay? Any questions?
Is that usually from over rotation or?
No, it's probably not either centering appropriately this way, like going too far this way.
Oh,
So you gotta make sure you center
right
on the sternum, or maybe like a collimation issue. Okay? Take a big step to your right again. Let's do this PA real fast. Okay. Chest up against there. It's like we're shooting a chest x-ray all over again. A little bit of light above the shoulder. Put your chest up against there, take a small step to your left. Your other left, girl. You're just doing what a patient would do, right? That's what patients do. It's okay, girl, it's okay. We don't know where our left from our right yet, but we'll get there. Alright, abduct that right arm just a little bit for me. Okay. Don't have to abduct it that much. There you go, okay. Okay, take a big breath and hold it. And you beep it. And then we're going to do the oblique. So these are for anterior ribs. So we're going to take her. We're going to oblique her. Halfway between her spine and her lateral rib margin, which is about right there. I'm going to open this up just a touch more. Abduct that right arm again for me. Come over this way just a little more.
So we're looking at the right side of this.
No, because we changed the
Perfect.
side of the spine. Yeah.
Because it's kind of across the circle.
Full inspiration.
Unless you can
Right.
Huh?
We're interested in the right anterior ribs and
The right anterior. Yeah. Yeah, we're looking at the right anterior.
because the ribs or the spinous process.
Okay, we're good? Okay. You can sit down for a brief moment. Leave your marker here until I use you again.
Jack was saying that.
After last week.
Good, what is with you in that dang water?
Moving over here now.
What's Jacqueline saying?
Don't forget to change the marker from left to right when you rotate the patient because the spine, you know, could be changed.
I'll pick the area of interest, the site of interest. So I'll give you I'm not gonna have you do both though. You won't do both.
Okay.
You won't start off AP and then do PA.
Oh, okay.
Does that make sense?
Yeah.
So I'll say, okay, no, you got right anterior rib fractures. So you automatically start with a PA with the right marker.
Okay.
Makes sense?
Yeah.
And then when you do the lower AP, do me a favor, can you hit that little, there you go, sleep on me. And then when you do the AP, you flip the patient over, just make sure you stay on the same side, 'cause I will mark you off if you go on the opposite side. So stay on that right side, right? stay on the same side of interest. Does that make sense?
Yeah, so going back to what they just said about the marker placement,
Uh-huh.
it's very similar to the last chapters, right?
To the
Where
left.
like, very similar to placement to the last chapter. So Janice was just an LAO. So if you put the mark on this, it'd be a right, but if you put it on that side, it would be a left.
Well, we wouldn't put it on that side.
Right, but if you had
because
to, I'm
you
sorry.
don't, you can't.
No, okay.
You can't, because we're looking at the right side.
He's gonna tell you.
Does that make sense? We're only looking, we only
when you-
do PA projections and the LAO position for the right side only.
So when
Okay.
you give you the interest, then you just put your marker there, and that's the.
Does that make sense?
Okay, yeah. So it's not like the spine.
You would never put it on the left side because we won't even see the marker anyway. It won't even be on the
So
column.
we're marking area of
That's true.
interest.
We're marking the area of
That
interest.
side of the body,
Well, both.
both, but I mean,
Right.
like, we can't just think of it, oh, just mark the correct side of the body. Like,
Yeah.
we have to mark.
That makes sense. So it would be no collimation. You would not get it. Okay.
Yeah, you wouldn't even get it, yeah.
So we're not doing that with the spine. We're just fine.
Yeah. But I like what she said, we're marking the area of interest and the side of the body.
Okay.
Can't just think of it like last chapter,
Yeah.
Right.
the spine is
So let's just wrap this up here. Let's put a bow on it. So basically, we did 5 views, right? You determining whether or not you're going to do them standing or lying down depends on the patient, whether or not they're ambulatory or not. If the patient is ambulatory, you do them standing. I would never lay a patient down on broken ribs. But if they're not ambulatory, then you do all of them lying down. Also has to include a chest x-ray. So we basically do 2 for the uppers, 2 for the lowers, and a chest x-ray. AP or PH, depends on the patient. A lot of people get confused when they have to do them laying down. Sometimes I'll shock somebody and say, hey, do them recumbent. And they're like, oh hell, I didn't practice them recumbent. And all of a sudden, everything just goes boop, right? And you guys go blank. It's like, well, what the hell just happened? Because all I've ever did was practice them standing up. But if you think about it, isn't this, and if you're to turn it like this, exactly the same? It's the same thing. And it's actually easier on the table because I don't have to say, hey, Janice, take a little baby step this way, take a little baby step this way. So you're not constantly
You
moving
just
the
move the
patient back and
table.
forth. Yeah, here you just line the table to the bucky, and you just, or the bucky to the tube, and you just move the table around, right? So don't get confused if you have to do it lying down. That's the same thing. And we'll actually take x-rays on the mannequin today laying down. So you'll see it's the same stuff. Okay? Also, you know, if you guys, you remember that link I sent you guys, it was a while ago, a couple weeks ago, and I talked about that guy, the author was some technologist, or he was talking about when he was a student. You know, I recall being a student, man, and I learned something this way, but when I went to the hospital, I was like, oh no, this is how we do it here. And even from tech to tech, right? You know, tech to tech, who had told me, who says, you know what, Scott, you can't do it like that, man. This is how you send it for this, and I'm the student. Oh, okay. And then Noe comes in, the other tech, and says, you know, what the hell are you doing, man? This is how we do it here. This is how we do it. And it was like completely different than what she taught me. Even though it's the same, you guys even went to the same damn school, but it's like different shit, right? You know, so it wouldn't serve you right if I did not tell you what they do in the hospital. So I'm here to tell you this is exactly what you need to know for your written test and your national exam. You take the proper history of your patient and you figure out whether or not what the projection is going to be. You guys are going to have scenarios where the patient comes in with anterior rib fractures. What's the best view to demonstrate anterior? So what do? You're doing PA, right? What about axillary rib fractures? So these are the axillary part right here, right? This is all axillary ribs. This right here and this right here, right? So your axillary ribs go like this. Imagine if the tube is right in front of this patient. It's going to throw this whole rib, right, this from here to here, right over itself. And you're not going to be able to see it very well, right? So in order to get these and see these, we have to oblique the patient to put them parallel to the image receptor. So we do this, right? So now all of a sudden it puts this area parallel to the IR. So if I were to ask you like which view is best done to demonstrate right axillary rib fractures, what are you gonna say?
And L, P, O.
Right. I
Downside.
switched sides on you. RPO,
Downside.
right? So now it's gonna put these axillary ribs parallel to the image receptor. But you can also deal with the PA projection too. If I want to see this side right here, how are you going to oblique the patient to where the spine, the fin is away from the area of interest? And LAO. So now it put these axillary ribs now all of a sudden are parallel to the image receptor. So on your test, you're going to have like scenarios, and you're going to have scenarios on your national exam. Patient comes in with, left-sided axillary fractures. What's the best views that will demonstrate this? And it may not even have lower ribs as an option. It might just have the upper ribs as an option. But they came in with left axillary rib fractures. What two views would best demonstrate that?
RAO,
So you'd probably do an AP and an LPO, right? Or a PA and an RAO. But one or the other. You wouldn't do both of them. Make sense? So anyway, make sure you guys look at the protocol books. Have you guys been checking the protocols where you're at the hospitals? It tells you exactly what views to do and how many to do and all that good stuff. The ribs, when you guys see the ribs in the hospitals, the protocols are so different. You know, what I teach you here is, like the basic stuff, and it's correct, and it's going to help you pass this class and course and pass the national exam. But what you see in the hospital might be totally different. And what you see in the hospital, those protocol books are written by the physicians. Dr. Smith says, hey, this is what I want to see for my ribs. And whatever Dr. Smith wants, because... Huh?
Different doctor, they want like different.
Oh yeah, and even doctor to doctor. It's like text, right? You not only do you have to figure out what the text wants, different text, but you also have to like, who's working today? Who's reading these images today?
Yeah.
It's like, oh hell.
Like, oh no, they wanted this way.
Smith's working today. Instead, for that L spine, you gotta open up like an abdomen. They want to see like everything, or SI joints. So you gotta include both SI joints for one view
That's what I
versus just.
noticed. I was like, dang.
Spock was like that.
Yeah, so it's the same.
doctor.
Yeah, for doctor to doctor, right? Yeah, different orthopods, they want to see different stuff. So you got to really pay attention to the protocols and what those doctors want, because they're the ones who are getting paid the big bucks, and the liability falls on them. So whatever they want to see is what you do. It's not that I'm teaching you wrong. I teach you the right way. It's just the protocols are different because this is what the doctors want. So the doctors may say, you know what, I want to see this view too. So whatever they want to see is what we do, what we give them. Okay? But you just got to remember, this is how you're going to pass this test. And the national exam, this is how you're going to be tested. You're going to give scenarios, and you're going to have to, by the patient's history is going to determine which projection we're going to give these patients. But I'm here to tell you, in the hospital, about 95% of the hospitals and the techs out there will always do this with an AP projection. They don't care where the area of interest is. I don't care if that patient got hit, smacked in the chest, and they broke all these ribs in the front. They're shooting them with an AP projection. Even though I trained you guys to shoot them closer to the IR with a PA projection, right? And it's not that I trained you wrong, it's just this is what they want to do and this is what they want to see. So most always you will shoot these with an AP projection in the hospital. But you can't forget what I teach you a year from now or a year and a half from now when you're about ready to take those boards, and all of a sudden you get test questions and they give you a scenario and it's like, hey, what do you do for these ribs? Well, we always do them AP in the hospital. At that point, they don't give a damn what you do in the hospital. They want to know what you were taught and what's on in the books. Okay? So you have to just remember that. Don't forget. After you start going to the hospital more and more and you see more and more ribs and get more repetition, you can't let the stuff just go out the door. You got to remember it. Okay? So not only do they do, weird stuff, different projections and things like that, they even do this, multiple hospitals that will even do this. So if you have like left-sided rib fractures, regardless of if they're anterior or posterior, they're going to shoot with an AP projection. But a lot of times what they'll do is they'll do like your, your proper center and all that stuff. You do your AP, they do the oblique, and they oblique them this way too. So they do what's called the upside and the downside. Right, so this is like the downside for my left ribs. Then they would pull it away from the IR and do the left ribs this way. So there's a lot of hospitals that do upside and downside ribs. I think CRFC does them. I can't remember if Clovis does or not. Kaiser or Kuya Delta does. There's a lot of places that do those. And it's not because it's what's taught to you guys, this is what they want you to do. Okay? Now some places don't even do lower ribs. They get ribs, they just shoot, put a little light up there, they shoot your AP, oblique, and call it good. Or AP, oblique, and oblique, but they don't do lower ribs. So there's a lot of different protocols out there and things that you'll see, that you'll run into. Key is you got to be able to do what I teach you and pass the tests, this in the national exam, and then also be able to handle what they throw at you in the hospital and do what their protocols are too. But I highly recommend you guys look at those protocol books and get them memorized. Get them memorized because you guys will have this summer. You should be like running your own room this summer. You guys should be just like kicking booty and taking names this summer. Okay? Any questions on ribs? No questions? Alright, Denise, come here, girl. I'm gonna use you one more time. You got it way too easy for that one. Let's do her sternum now. So sternum, think of a sternum. Think of when we do like an APT spine. And your patients are flat on their back or standing up or whatever. We're basically centering around the sternum, right? How come we don't see the sternum though? It's because of that big old spine, right? So the spine and the sternum are directly superimposed over each other. But the sternum is only like this thin, or thick, right? It's pretty thin. But the spine is this big old huge massive piece of bone back there that's absorbing all these x-rays. So we don't see the sternum on a regular P or AP straight shot. So we have to oblique the patient. So you said the heart. What we want to do with the sternum is we want to oblique the patient in an REO position to where we throw that sternum on the left side of the thoracic cavity and in the heart shadow. Supposedly it's easier to see the sternum when it's in what they call a homogeneous shadow. Homo means same, right? So homogeneous means like the same density. So that's why we do an REO. We want to project the sternum into the heart shadow. And we do that with an RAO. If a patient cannot do an REO, the alternative view is an LPO. Okay? So what I like to do though, put your back up against it for me. I like to start in the AP projection. Take a small step to your right.
Homogeneous what?
Shadow.
Homogeneous shadow. So I like to start with an AP projection because it's easier to palpate the sternum and figure out how high or how low to center. So when I do this, I put my finger at the jugular notch. I want about that much light, about 1 inch of light above her sternum, her jugular notch. So it's about right there. Okay, so that's about that much right there. We gotta remember too, the taller patients like Nick is gonna have a longer sternum than Janice. So I say collimate to a 10 by 12, but if you need something bigger than that, open your collimation bigger. Go to 14 inches. But you still put the top of the light 1 inch above the jugular notch. Okay? So once you get that, put your chest up against your foreman. I'm gonna pre-mark this too. I'm gonna mark it down here on the right hand side. So marker goes down and out, down and out. And what you're gonna do is you're gonna put your patient in an RAO. Your book says 15 to 20 degree angle. The thinner you are, the more you have to oblique them to get the manubrium of the sternum away from the spine. So if you notice that the manubrium is touching the spine, you're going to have to increase the obliquity more.
That's a test question.
It totally sounds like a test question.
So, if the manubrium is touching the spine?
If it's touching the spine, you got to oblique it more.
Right, to open it up. Okay.
Yeah. But the thicker you are, you only need about 15 degrees. Like neck, I can probably do with 15 degrees. Janice, I may have to oblique her 20, maybe even a little more, 25 degrees, just to pull that manubrium out of the way of the spine. So the thinner they are, the closer the sternum is to the spine, and the more you have to oblique them to get them to clear each other. Okay? So now we got her oblique, palpate her spine, and you're going to send her 2 inches to the left of it.
What do you say?
So here's her spine right here.
Oh, okay.
So 2 inches to the left of the spine. If you notice that you have all kinds of light over here on the right hand side, your collimation's either opened up too big or you need to center more this direction. We know the sternum isn't on the right side of the spine. It's going to be all the way on the left side of the spine. So if you palpate the spine, and I have all this light,
You said 2 inches?
lose some of it. Centering point's 2 inches.
And do we want any of the light to overlap the spine or just?
You really don't need any overlapping. I mean, you may have a little bit, but you're not going to see the sternum on the right side of the spine. Okay? So that's the RAO. And then put your left side up against here. And I'll take this as well. Okay. Now we're going to do a lateral view. So let's get her in a perfect lateral. Just like so. So this is the 72 inches. So you're going to back this up to 72 inches, the tube. Okay? And then what you're going to do is you're going to stick your finger in her jugular notch again and look at the shadow. I want about 1 inch of light above the shadow of my finger. So it's kind of, this is the top of the IR right here, so it's not quite 1 inch yet, right? So I'm going to bring this up a little bit higher. I'm going to bring this up a little bit higher. That's probably too high. Okay, perfect. Alright, see the shadow of my finger on the bucky?
Mm-hmm.
So we got that. Then what you got the patient do is reach behind her and roll her shoulders backwards. Take a small step that way for me. I want to make sure you're touching the bucky so you don't wobble on me. Go back a little bit more. Very good. That's good. Make sure she's in a perfect lateral position. And see this line right here? I'm going to do this again, Janice. Don't worry. Look, I can't see it. I want that running through her manubrium, so I want it like in this area. So I take a small step back again. There you go, perfect. So now it's running right through the manubrium in this area. Don't use the AEC chamber on this. Use your own manual technique. Because it's going to be really hard to put that little thin bone right over the chamber. You have a question?
It was the vertical line you want lined up with
The vertical
manubrium?
line up the manubrium. And I would even take this, and I would do this. Because her sternum is like this. It's not straight. So usually what happens if you don't turn this collimator, you end up cutting off the xiphoid process down the bottom over here. So turn this to match the angle of the sternum.
The SC joint like good landmark to kind of like line that vertical line up with?
Yeah. Yeah. Manubrium, SC joint. Same thing.
And again, bottom of the light, we don't care because all we're caring about is, or the line up.
Well, you know, you can always do is, you know, if you have a patient that's like super tall, you can always have them put their finger on their xiphoid tip.
Okay.
Right? You can always do that too, just to check it, just to make sure you don't cut it off. For example, if you saw that if she puts her finger there and her finger's not in the light, just open it up more this way.
Okay.
Can you show me where your xiphoid tip is? So it looks like it's right at the light. You gotta remember too, the divergence of the beam will put it in the light, but that doesn't make me feel all warm and fuzzy inside. So what I would probably do is maybe just open it up. That way it's a little bit more,
Okay.
right? That'd make me feel much better. All right, Janice, thank you very much. Take your markers, girl. Take your markers. All right, now come here, man. Huh?
I was gonna say, do you want me to take pictures of thing?
Oh, that's okay. I'll get in the way. Are you filming over there?
Yeah.
Oh, here, that's okay. I'll get in
Draw a
there.
box on me.
What?
Just draw a box on my face.
I'll go.
I can get Nick if you want. You good?
You want me to draw a box?
Yeah, just drag and draw a box on the screen.
Like move the box.
My
No.
fingers?
Yeah.
Joe, are you really gonna shut
Zoom
through
in,
this?
draw off.
No, this is.
We're good.
Oh, wow.
You do it?
No, just one finger.
No, one finger. All you have to do is just go like that.
Oh.
Did it make a green box?
No, just made a yellow box.
No, you want the green box on me.
Yeah, draw a box.
Just grab it from a corner and pull it down,
Oh, okay.
and then it'll track me.
There you go. That's awesome.
Fancy.
You should have got it, Mr. When I sent you that
know,
link.
man, I know you
Oh, it went on
did.
sale the other day.
Yeah, it was like 180 when I sent it to him a couple months ago.
That's pretty sweet. All right, take a step this way a little bit. You're too big. There you go. Perfect.
That's some high tech.
All right, Janice, this is all for you, girl. You ready? Jugular notch is right here, right? So I want a little bit of about an inch of light above his jugular notch, just like that. And if you guys also wanted to check this too, you can always palpate or have the patient check his xiphoid tip, and it's right there. So we have all kinds of light right there, right? We're definitely gonna get that xiphoid tip for sure. But once you get this, we're just gonna line this bucket up. And then put your chest up against it for me. Alright. So we're going to put him in an REO position. Just like that. Spine's right here. We're going to go 2 inches towards the upside. And we can put our right marker over there. I would prefer to put the marker down here in the corner. So I would have preferred to like pre-mark the bucky. Okay? And again, if you see the manubrium on the spine or touching the spine, you will break the patient more. Okay? Put your left side up against there, sir. And let's see, let's punch you like this. Bring your arms behind your back, lower your shoulders forward, there you go, and just take a step to your left. That way it helps balance you. Come towards me a little bit. I love this little camera on the wall, man. Don't you wish you they have that in the imaging rooms? Because you know we're constantly doing this, and we're doing this, and you guys like, oh, you can just do this. That would be so sweet,
That's your $1 million idea right there.
right? That would be like the sweetest thing ever. So right there, it's running through his jugular notch, and then we're gonna take this and do this. Wait, did I measure? I don't think I measured this first. Let's see here. Oh yeah, we're good. We still have light above my finger.
Right? 72?
Yeah, he said to move it to the 72, but he didn't.
Yeah, it's at 72.
Yeah, I didn't move it though. It's been here the whole time.
Right.
It's at 72. I moved it. You just didn't see it. Don't pay attention to those numbers because it's at 72.
You measured, right?
I measured. Janice, you got questions? Okay. Okay, we're good. Alright, you can take a mark. Actually, you know what? Stay there. I'm going to get you now for the SC joints.
Good one.
Okay, so SC joints, these are done at 40 inches. Do me a favor, take a big step that way for me.
Uh-oh, it turned upside down. Oh, wait.
You just tilted the camera, or the phone, it's fine.
So sternoclavicular joints, they're right here. Tiny little joints, right? That are right where the manubrium and the clavicles meet. So they're very close together. All we need is a cute little box in the bucky. Just like that. And I'm going to even pre-mark it. We're going to do these PA because it puts them closer to the image receptor. But we're going to start off like we did with the sternum and start off AP. So all I'm going to do is I'm going to start off, put it back up against here. And I'm going to center right on this jugular notch. Just like that. Take a big step here, ready for me? Okay, and then put your chest up against here. And then we're going to center around the spine. Just like that.
SC joints.
PASC joints.
And that box is like a cute little box.
Cute little box.
And
Oh, that's
like it
in the
says
measurement.
8 by 10, but
8 by 10? Oh, hell no. I'd go like a 4 by 6, like a 3 by 5. You don't need very big. Just a cute little box. And then we're going to do an REO. 15, 20 degree REO. And we're going to center 1 inch to the left of the spine for the REO, which is like right there. And then we're going to do an LAO. Here's the spine, 1 inch to the right of it.
just 1 inch.
Just 1 inch.
This is another 2 inch.
I'm feeling 1 today. 1 inch will get it.
Thumbs up.
Excellent.
Good on you.
So check this out. So this is what we're looking for. These joint spaces right here,
I'm
right?
all confused.
So this is my patient. This is Noe. Noe lost some weight. A little thinner.
Slowly.
Bounds.
Let's go.
Okay.
No eating.
So remember, we start off like this, right? Mark it right here. Right marker.
Corner.
Upper right hand corner. But when we shoot them with a PA projection.
Oh,
So then you center it at the spine.
Oh, so
Like
line
that.
it up and then
Yeah, so I line it up and then shoot it. Oh, sorry, we didn't show you, huh? I'm showing you right now.
okay, yeah, we're good.
These are pretty easy. These are pretty easy.
We'll check the dates.
So then what you do is you do an REO. So the REO, what happens is it takes, keep an eye on my SI joint. It's right here, right? My right SI joint. Watch where it goes. Where'd it go?
Over there.
To the left of the spine. So in the REO, we're looking at the downside, which is the right, but it's going to project it on the left side of the spine. Make sense? And then when you do an LAO, and this is why we center 1 inch to the spine, because it's going to fill the joint space like right in this area right here. And then when we do an LAO, it's going to take the right SC joint and throw it, I'm sorry, the left, and throw it on the right side of the spine. So the left SC joint and throw it on the right side of the spine. And then we're going to center 1 inch to the right.
And now these are you still marking?
You can just
right
keep the
at
same
solidly,
marker.
Or you're, okay, so we're just.
Yeah, you just keep the same marker on there. Yeah.
So it projects.
But don't mark it for an AP and then turn them around and forget to put your
Yeah,
marker
don't
on
put a
there.
left marker on there and then flip them over and also on the right side. You have a question?
Well, I was just gonna reiterate in less words. All it does is projects the opposite side SC joint on the other side of the spine.
Yep. That's it. Easy breezy.
And it's easy.
So that's it, guys. So this is gonna be like a super easy test for you guys. It's gonna be super quick. I'll give you guys the area of interest. And but I'll give you guys the area of interest and you do whichever oblique you think is correct for that body part.
Okay.
Okay, does that make sense? So I would say, hey Nick, you have a patient here for left posterior rib fractures. So what are you gonna do, Nick?
Left posterior, well, I'm gonna put him in a AP position, and if it's left posterior, I'm gonna put him in a RPO.
LPO. So left posterior?
That's right, I'm sorry, because I need to throw the spinous processes away from the first. So.
So let's remember, it's 5 views though.